Okay, I think we can start. I'm Rainer Sauerborn, and I'm the course director of the MOOC Climate Change and Health Week 2, and announced to you that I would give you some feedback on your questions, and not all, but on some that may need some elaboration. So thank you very much for your many questions. Have been answered by either me or my course assistant. If not, please complain. But there were other questions that are more of general interest, and I think of them. And the first is by Elamon. I hope I pronounced the name right, correctly. Is the or tool to calculate or assess solution to climate change? He or she poses this question under the video malnutrition. Well, you put really your finger in a wound. This is the challenging question. Research on health impacts in general, and particularly on malnutrition. So how do we attribute, scientific community attribute something to climate change, acknowledging that there are many other factors, and malnutrition is a case in point, because this is something that is so complex. There are food prices, there is diseases influencing malnutrition of children. There is, of course, diarrhea, and there is the harvest of last year, there's climate, there's El Nino. So how do we tease out that part that's really due to climate change? In principle, we have three options, and let me have a look a little bit at my presentation in our course Research Methods on Climate Change. So either you do an analog study. That means any disease that has a seasonal sensitivity, goes up and down with the seasons. Classical cases: malaria, dengue to some extent, and meningitis. So that have shown and proven, if you like, to be sensitive to temperature. They are very likely also to do climate change. So there are some ways where you can transfer seasonal studies onto temporal and spatial framing. Very complicated, and I invite you, by the way, to the course in attributing climate change to health, attributing health to climate change, that we are setting up in Heidelberg. In any case, so that was analog studies. And the other one is looking at data longitudinal way. Ideally, let's say 40 observation of representative population of your country, and your everyday's temperature, everyday's rainfall, everyday's humidity, and so forth, at the same measure all these incidents in their mortality. And then after 20 years, at least 10 years, climate change, you need probably 20 years to figure out whether something changes. So after 20 years, you can then say, oh, this and this disease, and there's a clear relationship, and that out statistically. If you're interested in some leads, but you have to figure out a little bit by yourself, or you do a PhD, or you do some research on this, training on this. So the method is called time series. And so what this does is it looks at the lags, which means at the time difference, let's say heat wave, and an outcome, let's say cardiovascular or stroke or cardiovascular death. And in Europe, it has been done by us in Burkina Faso, by others in Delhi, by others in Brazil. And that you need data sets, good quality. And for heat waves, you don't need so long data sets because the effect is so large that you can say that heat wave caused so many deaths. Whether that heat wave was not climate change is another debate. So for climate change, a very long data set, there are such data sets. And if you look up www.indepth-network.org, you will find 56 population cohorts, Africa and Asia. Only one in Latin America, I'm afraid. Measure health, out death, but some also incident cases of diseases. And they do capture these over decades. Started in 1960. Chest of longitudinal data. Now, where do you get? None of those sites record whether since, let's say, there's hope. You download from NOAA or from the World Meteorological Organization. There are public domain websites where you can download for each day, each cohort right now. You want to know what the temperature was on the 5th of August in January 2001, look no more. So you can put a timestamp, if you like, on all adverse death area, like a case of malnutrition and so forth. So this is the high road if you really do empirical work on climate change under observation. However, not ongoing, because it takes too long, but in the past. You remember there was that slide from Tony McMichael, observe the present and project in the future. This is a very wise statement, and it can be done. For example, in the case of malnutrition, in a large with other centers who are good at climate modeling and so forth. So that is the best way of doing it. Data. And probably you know that, there's a WHO exercise which is not based on sort of data from one set of a population, let's say a district, and they have very standardized quality, but they do a very, very good job in putting together all sorts of data sets and reported data, which have their problems, of course, together and look at the best estimates that if you have a peak in malaria in Malawi and in another country, and the weather like this and that, kind of a global effort to have the best estimate. Some might say guesstimate, because it is really putting many studies from many sites in different time frames together, that we can do a great job in doing it. And this is downloadable from the WHO website. And so it's called Global Burden of Disease Project, the sub-study on risk factors and their contribution to the global burden. And within this sub-study, it is the risk factor climate change. Okay. Are more sort of qualitative. Many of your countries have climate health impact assessment. That's, we call it a Delphi, D-E-L-P-H-I, from the Greek town of Delphi, where the oracle specialist gave guesses on the future, concerning the future. Now, but very often the best experts in the room, based on data, based on experience, is very valuable, and it's country specific. So if you have an agricultural person, and if you have a health person, and if you have a climate specialist, and Matthew and the Ministry of Health, they come up with useful ideas, and they have looked at the literature. They came up with useful, if not scientific, estimates of what could be in store for them in terms of climate impact. So these are some of the elements of attributing climate change, attributing health impacts to climate change. There is the classic, there's a classic epidemiological calculation, which some of you may know. It's the attributable risk, AR. And I will put on the internet, on the website, there's attributable R, and there's population attributable risk. Now, this is not rocket science. The main thing is to get the data, and if you have data on health and weather in a long term, you can also do the mathematics to tease out the effect. I'll put it on the website, and those of you who are really interested, go for it and look it up, textbook. This course was not how to do research, otherwise we would have approached the debate on to initiate you, to tell you what is the link between health and climate change. How to prove it, story, and I would invite you, those who are interested in research, who have curious minds, come and join. There are not many in the world to do this, and it's a very exciting, if cumbersome, task. So there are no standards. It's not like you name it, you know, like land use assessments, but it's really. As for this question, now the next one is also by Joy. Joy is a very curious mind. You rightly refer to the two commission reports, seemingly the first in 2009 said health is the largest global health century. It was kind of alarmistic, maybe a little bit too, but it was a wake-up call, because at that time nobody really had this problem on their radar. So I congratulate them that they did this. And they put evidence, the evidence that there was, which wasn't fantastic, admittedly. They put it together and they made a very good case why this could be really the last century if we sleep through this. Yeah? And now, 6 years later, the same commission, well, other people were involved, comes up with the greatest opportunity. So people ask me, is to change from bad to good? The answer is no. It has changed from, you know, just a different way of looking at something from that angle and from that angle. If we don't do anything, and I made the case probably pretty clearly in lectures, if we don't do any of adaptation, there are health effects that go to the extent that some territories become unlivable, that people cannot work, and so forth and so forth. So it's still true, but there is a kind of hope aspect in here. And you're right to point out that largely this is due to the evidence on health benefits. So the cardiovascular health benefits, the cancer risk health, particularly benefits from fighting local air pollution and fighting also outdoor air pollution. And both of which have a very strong health component. So the kind of catchword, what's good for the climate is good for you, only appeared a couple of years ago. So there is a change in and new evidence, and you see how evidence shapes the debate. So we have now clearly the argument on hand. You have a choice. Either you don't do anything and you go down the very bad road, which is still the largest of the century for if we don't do anything, or you go the other road and there is effective climate policy, then you reap enormous health benefits in addition to saving the climate with all the other effects. I hope this is good for now. If you still have questions, Joy, please give me a comment and I'll respond to you. Now, the next one is an easy one. Some of you were kind of complaining about the dengue quiz question, and you said it was Martin Kassel that you had a problem with this question. Whenever you clicked on risk of dengue is higher in the Horn of Africa, it said, no, wrong. And it's correct. There is no dengue in the Horn of Africa. There is no dengue. Look up type Google a world map of dengue, and you get the distribution, and you will see in North America, I mean, barring exotic cases that come from airports and you name it, practically for all practical, because there is no dengue in the United States, barring exceptionally rare cases. But south of that, there is practically no dengue in Europe, Russia, and you name it. So the north, but also the south, meaning the southern tip of South America, and the southern part of Africa is dengue-free. That doesn't mean that the mosquitoes are out there. That doesn't mean that it cannot change with climate change. But for the moment, it is like this. Also, the southern part of Australia and New Zealand are dengue-free. But dengue has encroached already on the north of Australia. So this is not a static map. But for the moment, we asked you, is the risk of dengue highest here or there? The correct answer would have been no, this is wrong. The risk of dengue in the Horn of Africa is not higher, because it's not. Let me see. Well, I think these were the three questions, not four, that I wanted to discuss with you in detail. As I said, I will put some material for those of you who want to go into this research question a bit further. I will put a lecture that I give in my presence course. The next course will be in June this year. So look up the website, Heidelberg University Public Health, then click teaching, and then you can see how to register if you're interested. In that course, we will go to some depth in looking at research techniques, but it's not yet the course on research methods that we are currently developing with our colleagues in Umeå, Sweden. Umeå, Sweden currently has a course on research methods, which I set up with my colleagues there about 5 years ago. So that's another option. You can go there. Umeå, UMEA University, click Global Health, and you will get to where to register. So I hope this is helpful. Give me a feedback if it was or if it wasn't. And see you next Friday, 5 o'clock. Thank you. Bye-bye.